Thank you, Judy. So yes, as Judy said, I'm Sharon Kirby. I'll highlight that I'm the former CNIO for Mayo Clinic. It's only 15 days now, so but I have been with them the past 3 years and through the pandemic, and so do definitely have some insights from that. What I think we really want to consider around nursing documentation, the burden that's created is, and also around medication reconciliation, is that we need to ensure that we're not just looking at this in a silo. So nursing documentation, and I think this point was brought up by some others, you know, is this a thing of the past? Do we need to realize that we have come so far as to look at this very differently? Do we really want our clinicians manually entering data? And so I think that this is time for us to really have a paradigm shift on how we view this issue. And one thing that I want to make sure that we're not missing, you know, we talked a little bit about the CMS final ruling around the reducing physician burden around documentation. We want to make sure that as we're looking at this, that we're not shifting that documentation to nursing or other clinicians. We really need to just be ensuring that we have parity around the documentation, who is documenting and what makes sense. And I think because it's really targeted toward physicians, I think that we just need to consider also our other clinicians, that this is not just causing another burden for others. I know shortly after I began my role at Mayo Clinic, I quickly heard the term clerical burden, that the physicians were experiencing much clerical burden with their EHR documentation. And I have to say, I never heard about that burden for nursing. And so I do think that we have to be thinking about all of our clinicians when we're talking about the issues that we have around the documentation. It's very published. There's a lot of publication in the literature around pajama time for our physicians, but not so much about overtime that nurses are putting in to document after their shift, and the burnout that's creating for them around their missed opportunities with family and other obligations, et cetera. And I think we need to be thinking about things such as just workflow, such as medication reconciliation and the pain points that that's created for our physicians over the years. And, you know, it's a clerical issue for physicians, but it's also medication ordering. And so it's not really something that's in the scope of nursing. And so we look to our friends, our EHR vendor friends, and although they're well-intended, maybe making the workflow even more cumbersome. And so I think we need to be looking at not just the documentation, but the workflows overall. So how did we get here? I like to say we had too many cooks in the kitchen, or we're trying to serve too many masters. And as was already mentioned, you know, we're trying to serve regulatory and finance and institutional policies to try and ensure that we're documenting what we need to be documenting. We also are trying to use it to hold our clinicians accountable. And so I often think of a meeting I was at with CNO leaders across an organization that I worked with, and they were trying to solve for their Pneumovax capture, that they were not getting the Pneumovax screening done, or they need to get their numbers up to meet regulatory requirements. And they were brainstorming some ideas. And then as often happens, they look down at the end of the table and they say, Sharon, just put a hard stop in the EHR and that'll make everything better. And I know many of you on this call will that just, you know, it cringes the thought of a hard stop is the answer to things, which we know it is not. And also the other thing that causes me to cringe is when I hear, well, the nurse can just blank, 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 or then why doesn't the nurse just blank, 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 as it's a catch-all. If no one else is going to do it, then well, let's just have the nurses do it. And so I think we have to be careful about what we're asking nursing to do in this realm. And so we really need to call on our healthcare leaders to share in this accountability, that we do have a documentation crisis and that they need to be part of the solution and not continue to be part of the problem. And so we really need to be thinking about this issue in a three-pronged approach for documentation reduction, as well as concurrently looking at how are we going to address the standardized terminologies and data sets so that we can be sharing this information, and how do we automate as much as possible to eliminate this manual documentation. And so Linda Harrington had a wonderful publication around the future model for nursing documentation. It doesn't need to be become extinct. And she really has some interesting thoughts in this publication, asking, have we really come very far from paper to electronic? In the paper world, we were batch charting at the end of the shift. I know in nursing, often we were doing that. And we're still seeing that in an electronic world. If we do that, we don't have real-time documentation. So we don't have, we can't support, the clinical decision support rules, and we can't support the AI algorithms if we're not, if the data is not timely, it's not valuable. And so we need to be thinking of that as we're not looking at this just as a documentation reduction, but also more holistically, our workflows and how we're documenting and when. And then automate wherever possible. So, medical devices and wearables and other technology, we're in a digital age, and how do we look at this EHR as not as a documentation tool, but more of a database that's holding our information and serving that data up to our clinicians when appropriate. So I think we really need to look at this as a holistic problem, because if we just try to put our finger in the dike, it's just going to show up somewhere else. And so as we look at this symposium over the next several weeks, and we break off into our work groups, I think we need to be thinking about this is not just a documentation reduction issue, it's more holistic. And as we talked about, there's low-hanging fruit that we can do over 3 months or 6 months, but we need to be looking at this opportunity overall. And I think a good model that Linda Harrington highlighted in her publication was an ESIA model that was first published in the Essence of Business Process Reengineering by Peppert and Rowland. And it talks about eliminating, simplifying, and integrating the documentation or the data and automating. And so with these 4 steps, it's going to be important if we looked at a model like this to ensure that we're eliminating, simplifying, and integrating first before we automate. Because automation, as we know, is a costly endeavor, and we want to make sure whatever we're automating is value add data and not data that we realize is not something that's value add to be migrated to, to the EHR. And so I think this is time for us to pause and look at what have we learned from the pandemic. We realized how much we can do remotely. Here we are right now, having a large symposium on a Zoom meeting. Who would ever imagine that we could do this? And so we need to learn from this pandemic. It eliminated a lot of barriers and gaps that we have in healthcare. And it showed us that during a crisis, we can eliminate a lot of those gaps and barriers. Clinical documentation was certainly one of them. And I know at Mayo, we tried to create a nursing documentation, a disaster navigator to shortcut some of the documentation. And we did that back in the spring with the first surge. And it went through so much committee and legal and regulatory that by the time they came back with it, there was very little changed. Luckily in October, we revisited that with the second surge and saw that we had other opportunities to decrease some of the documentation. And so I think we need to learn from what occurred with our pandemic. And so I say the time is now. I love this quote by Winston Churchill, never let a good crisis go to waste. And obviously we all know we've been in a crisis in the past year. And I just challenge us all to step up now and not just continue to acknowledge that we have a national crisis around the documentation burden, but to formulate and operationalize a national plan and international plan, obviously with other stakeholders here on this call, that puts us on the trajectory to really solve for this crisis and not just for physicians, but for all of our clinicians, so that we allow all boats to rise. Thank you.